and welcome everyone. Thank you for joining us for today's learning series webinar, The Biology of Addiction. A few housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU. And the Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers. And this program is eligible for a maximum of one category A hour or CEU. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days of today's date. After that, we will no longer be able to issue you credit. So you'll get information on how to apply for your credits at the end of this webinar, and you'll have 30 days to apply. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And once again, I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series, which it's hard to believe we're in November already. But I'm so pleased to welcome today's expert faculty, Dr. Holly Geyer. Those of you who have been with us throughout the year may remember Dr. Geyer from February's webinar. There were so many comments and interest on her presentation that we asked her to come back to do a full presentation today. She is the Associate Professor of Medicine and a consultant in the Division of Hospital Internal Medicine at the Mayo Clinic in Arizona, and she is dual board certified in internal medicine and addiction medicine and serves as physician lead of the opioid stewardship program, as well as medical director of the Mayo Clinic Arizona Occupational Health Services. And for those of you who were able to attend our Healthy Aging Summit back in September, Dr. Geyer was our keynote and so well received. So Dr. Geyer, thank you so much for being with us again. And we're really looking forward to your presentation. So I will turn it over to you.
Thank you so much. I appreciate the chance to be here. Let me grab some slides and we are going to get into an exciting topic today about understanding addiction. All right, we got you pulled up. Angela, is it showing up okay?
Looks good. Looks good.
Wonderful. Well, thanks so much for having me back. You know, the last time we talked, we were talking about the role of opioid stewardship within an organization. How do we use opioids safely, get it right for the patient and the right dose, the right length of treatment, the right route, using the right type of opioid. And I finished with a final comment on the topic of opioid stewardship. Opioid stewardship engages the right types of treatments should complications occur. But we didn't have time to really get in depth with what those complications are. And today I want to be talking about what I feel is the second worst complication next to an overdose with this drug class, addiction. You guys may have heard 1,000 lectures on the topic of addiction. What I'm hoping to do today is to demystify it, to understand why we've got this world of behavioral health. And then we've got doctors and nurses and pharmacists all talking about it as now being a medical disorder. And how do we reconcile these? Why did we diverge to begin with? What did we used to know? What do we know now? We're going to be tackling it today. So jumping right in here, this is probably right here, the number one question I get in my industry. What the heck is addiction, right? And we put it under this category of behavioral health. Well, let's sit here and ponder the word behavioral, right? Another word, if you look this up in Webster's, another synonym is conduct, right? How people behave. Is how people behave addiction? Is that how we define other medical disorders, as the behavior, or are there truly underlying drivers that we need to better understand? Now, when I ask this question to audiences or when they ask it of me, I get approximately 1,343,002 answers because it's entirely dependent on what people's background is with this topic. If I come to different organizations, and I know we have a very diverse audience here today, if I come to organizations that specialize in the world of psychology, right? Those that are in that realm of understanding mental health disorders, and I ask this question, what is addiction? The most common answer I get back is that it's driven by an underlying mental health disorder, such as depression, anxiety, bipolar, schizophrenia, one of those SMIs. And I get this answer, Dr. Geyer, if we could just go after those underlying drivers, right? The trauma, something that spurred it from the beginning, we would be able to address addiction. We would cure addiction. A driver, potentially, right? Something that provokes addiction, a natural outworking of the disorder in many cases. Absolutely. But is it addiction itself? I would argue no. We're going to talk about it. When I go to people who work in that social service realm, social workers, right, care managers, and I ask this question, and this it goes for people that deal with, the societal implications as well. Cops, right? People that deal with the kids who are now in our social justice system. What is the driver of addiction? They say, listen, Dr. Geyer, if we could handle all these social issues out there, right? The food security or societal pressures, right? Or issues with people, in incarceration. If we could deal with all this from a social standpoint and ensure there's food and housing for everyone, addiction would go way down. Drivers, potentially, right? Contributors, absolutely. Natural outworkings of addiction itself, absolutely. But it's not addiction. I speak to people who deal in that spiritual realm as well, pastors, people who, focus more on the existential components of our existence. And I ask them, "What is addiction?" And they say, "Well, Dr. Geyer, it's oftentimes our best understanding that it's a problem with a purpose in life." Or past sins that seem to haunt them, or a lack of connectivity to another group, or a lack of connectivity to God or a higher power. And sometimes we see it as sin. If we could go after those, if we could fix those drivers, addiction would go away. Contributors, I think so in many cases. Natural outworkings of the problem, it's hard to argue not. But is it addiction? The answer is no. We've covered most domains of existence except for the physical. And that's what I want to focus on today. How our understanding of addiction as a physical disorder has really changed over the last 20 years and how we use animal models to better understand it. Yes, your dog, your pet rat, please don't tell me you have a pet rat, it can get addicted. And floridly, right now, as we speak, there are animals all over the United States hidden in cages that would right now rather walk up and get a hit of cocaine while actively being shocked doing so as they're starving to death, dying, rather than eating the pile of food sitting right next to them in the corner. We are biological creatures, friends, and the biology changes in the setting of addiction. So we're going to learn here how to diagnose addiction as a biological disorder. And I think one of the best ways to compare this to is how we in the medical field diagnose individuals with active medical disorders. So congratulations, all of you right now get to put on your white coats. You are honorary doctors for the day. And I know we've got some true doctors in the group. Bear with me. Congratulations. We're going to meet Mrs. Johnson. So poor Mrs. Johnson, right? She has a history about 5 years ago of metastatic breast cancer. I'm sorry, not metastatic, local breast cancer, right? And they did resection and radiation. She got some chemotherapy, and as far as she knows, all gone. Things are good, right? She's coming into our hospital today because she's had some bad symptoms over the last month. She's lost about 25 pounds of weight. She has no appetite. Her belly has been swelling. She's nauseous all day long. She's kind of got these low-grade fevers. She's fatigued. She feels horrible. And she walks in and she says, "Doctor so-and-so, I'm a little concerned. What's going on?" So I want us to think through what should we do next for Mrs. Johnson, right? She just walked into your clinic, your hospital. So here's our answers. Are you going to pick number one? Do we start high dose cisplatin? That's a chemotherapy agent, right? I mean, and would it fit here, right? Poor lady, swelling, weight loss. How about abdominal radiation, right? What if it's all over the belly? What if her cancer spread? That might help fix it. Or we could take out the bowels, right? Maybe that's part of this. It sounds like she's got a bowel obstruction. Again, maybe that cancer in there. Or, holy moly, lady, are you insane? We don't have a diagnosis. Please tell me you pick number four. That's all right. You're intern, so we'll give you some grace. What's wrong with the logic of one through three? What didn't we do? Well, we didn't go through and identify what the underlying driver is, did we? Right? This lady, what if she has a gut infection, right? Or something else going on? We need CT scans. We need biopsies. If there's something in there, we need labs. We need pathology. And even if it was that simple to get to a diagnosis, then we can send it off for karyotape testing before we ever start chemotherapy to see if there's specific types of treatments that are less harsh that she might respond to. I mean, there's an algorithm. We want to use diagnoses based on evidence and objective evidence, things we can feel, touch, see, right, and document. So we've learned the hard way. Sorry for those who got questions one through three answers. We're not going to make that mistake again, but I do want to bring in Johnny, our next patient walking in. All right. So Johnny's mom brings him in. He's an 18-year-old who still lives at home. And Johnny's mom sits down. He's kind of reclusive. He sits in the corner, his arms are folded, and he says, I don't really want to talk today, but his mom is happy to. And she says, Dr. So-and-so, I want to talk to you about Johnny. Johnny has had a horrible attitude for the last 2 months. He's not talking to me. He is late for school. I've been called at least 3 times in the last couple of weeks for him at least an hour late, and I don't know where he is. He is not sleeping at night. In fact, he's up all hours of the night. I see the TV on. What's my kid doing? He's agitated. I ask him a single question and his personality is just off, right? And he's very withdrawn. He sits at the dinner table, he keeps his arms folded, and I think he's shaky. He dropped all his peas the last night off the spoon. There's something not right here. And I was putting away some socks and I found a little baggie of white powder. I don't know what it is, but I am very concerned about Johnny. So, folks, we just learned in the last case, right? We make decisions in our medical field based off objective features, right? Objective evidence, things we can feel, touch, right? Diagnose, biopsy, lab test. What do we order? So, we get labs on Johnny, right? His mom is clearly concerned about a potential addiction, a substance use disorder. What labs would we get? If he's not actively intoxicated right now or having used them in the last 3 days, there's not a whole lot we may get off Johnny, right? Maybe a urine drug screen would come back with some evidence, but if it's negative, does it rule it out? No. So maybe not labs. Brain biopsy. For what it's worth, I asked Mayo Clinic if this was an option. I got laughed at by HR. We don't biopsy brains to get to the diagnosis of addiction. Okay, imaging. At the least, we can get imaging, right? An MRI or a CT scan of the head. That would show us what addiction, right, would look like in the back of the brain. That will get us to the bottom of this. Friends, in the vast majority of medical centers, outside of a handful of a few academic ones, there are very few scans out there that diagnose addiction. And right now, it's not built into our criteria to make a diagnosis using imaging. That's not an option. Folks, we've got a problem here. We've been asked to make a diagnosis. We have no tools. And for years and years and years in the medical profession, this haunted us. In fact, for 50 plus years, we didn't know what to do with these people because we had no way to use our standard protocol to get to a diagnosis. And that's why, until I would say about the last 15 years or so, if you showed up in a doctor's office with addictive behaviors or overdoses or evidence of withdrawals or high tolerance, right? Somebody shows up and says, I've got a toe infection and I'm worried about it. And to be perfectly honest, I've been drinking a lot more as of recent, and I passed out twice last week. You as a doctor, if you're in primary care, or most other subspecialties would probably say, holy moly, well, I'll give you antibiotics for your cellulitis and Go find a treatment program. And out the door you go. This was another industry's problem. If we heard the word addiction, if we hinted at addiction, it was anybody but us. Now, the field of addiction psychiatry was steps ahead of us, fortunately, and at least they were pioneering in the field to help us better understand what might be going on in that brain. But that information was not disseminated to the rest of the medical world. You see, in the medical field, we really use a very different approach than historically how the behavioral health field has evolved out. Back in the 1910s to 1920s, the concept of addiction was largely seen as primarily moral failure, right? People making bad decisions and making them over and over and over. And if you go back all through history, there's documentation of us seeing it as such, even prior to that. But around that 1910, 1920 timeframe, that's when the behavioral health field started saying, you know what? We're seeing features that might suggest there's also a social component to it. And we start seeing over the next 15 to 20 years the emergence of another field where essentially communities would come together, people with similar problems, addictive behaviors, and form community bases or therapeutic communities where they'd mentor each other, those in recovery, helping those underneath them. And we see this, as we call it, behavioral health field start to emerge. Now, they diverged very differently than our medical field, which again is based on everything we can feel, touch, test, right? Evidence-based, randomized controlled trials, Cochrane analyses. We use objective features. We are very, very diagnostic dependent. What can we, biopsy or use as solid evidence to base all other future decisions on? In many cases, what we do is reproducible, right? If we see it in patient A, it's probably there in patient B, and it's a very standardized approach for many people. The behavioral health field evolved differently, right? For a long time, there was little evidence based, at least from a scientific standpoint, to understand how interventions would work on patients. The world of sociology made some advances, so did psychology. But again, it's more nebulous than we see in the world of medicine, where one lab should be pretty standardized against that of another patient. They're oftentimes subjective features, right? What do we do with Johnny being up all night? Is that insomnia because of meth use, or is that Johnny liking his favorite TV show at 2 in the morning? Limited diagnostics, we talked about that. And because we are dealing with so many different domains involved, that biological, psychological, social, and spiritual domain of living, right? Because again, we're talking about behavioral disorders. Oftentimes, how we treat one person may not be reproducible in another. And oftentimes, our treatments aren't standardized. So, behavioral health didn't look like medical. And in our world, of the medical world, we were okay with that until the opioid epidemic. Yes. The last 15 to 20 years, friends, has been revealing for our industry because out of all of our understanding from that 2000 to about 2010 timeframe when our logarithmic increase in opioid prescribing took place across the United States, to the point where in 2015, 1 out of every 3 US adults got their own bottle of opioid pills. Up until that time frame, all these complications we started seeing coming out of our prescribing behavior were considered what we call iatrogenic. We did it to you. We did it to our patients. We weren't monitoring, we weren't screening, we weren't preventing. And unfortunately, we were causing net harm. We owned this. And a ton of money started flowing into the space of understanding addiction better. We saw it through NIDA grants, CDC, NIH, and the evidence, overwhelming evidence of addiction as a biological disorder started to become clear. Addiction, my friends, is a disease of the brain, and quite frankly, one of metabolic and neuroadaptation mechanisms that looks very similar to other organs in the body that are compromised, including the heart, the liver, the kidneys, and others. So let's talk brain. What the heck is going on in this poor brain in the process of addiction? I grew up in the behavioral health world. My parents had started a drug and alcohol treatment program when I was a little kid, and this nonprofit, fledgling organization had a very limited understanding of addiction as a disease. We were a very standard behavioral health model. But as our organization grew, so did our knowledge. And I will say, when I started there, when I was a teenager, just working part-time. My understanding of addiction and the brain was that the brain is kind of like this giant panna right? You got a million connections going in 1,000 directions and maybe some red sauce flowing here and there, just, maybe some connections, but it wasn't well organized. And I think that's oftentimes how people still view it. But the reality is that the brain is the most highly organized organ in the entire body. It's built into very discrete zones, specific parts of the brain that are responsible for executive function. That's your frontal cortex right up here, that the part that says go, no go, or this, what I'm about to engage in is a really bad decision. I shouldn't do it. Mom took my car keys away the last time I tried a vape. I'm going to get in big trouble if I do it again. The answer is no today. We've got parts of the brain that move, the arms, legs, hands, feet. We've got memory centers. We've got centers that deal with emotional processing. And then you've got this very specific center called the limbic system. The limbic system is your pleasure center. We have all these connections, and all of these connections are specifically coordinated between different parts of the brain going in one direction as a 7-lane freeway or bidirectionally as a dirt bike path, so that certain parts of the brain keep other parts of the brain under control. That we move in coordinated fashions, and that ultimately your executive decision-making center for your problems in life stays in control. All drugs of abuse hijack that pleasure center. All drugs of abuse hijack the pleasure center. So, how do they do this? In that pleasure center, you've got a chemical, a neurotransmitter called dopamine. Now, dopamine is there and it goes up and down based on whether or not you've done something pleasurable, right? It's there for a reason. It's there to support activities of daily living for holistic living. So, an example of when dopamine would go up, eating ice cream. An example of when it goes down, broccoli. An example of when it goes up, hugging your kids, right? Going for a walk. These are things where you naturally will get some kind of a stimulant in your body, let's say endorphins or your naturally produced opioids, and they flow through your bloodstream and up into the brain and they activate that system. And once that system is activated, it causes a little surge of dopamine and that transmits the nerve signal through the brain. Now, normally this is under good control, and we've used rat models to better understand this process. I want to take a look here at what happened in a rat model when they studied what happened during normal production and what happened during drugs of abuse. So you can see here, 100% of basal dopamine output, meaning minute by minute, they're making what they should normally make. And then they give this little rat something like, I don't know, a rat donut, right? And you can see this little spike, 50 to 100% increase that goes up just briefly and then comes back down within a matter of minutes. This is natural. This is normal. That rat's going to want that rat donut again in a short time period, right? Drugs of abuse hijack this pathway. I want you to look here at this rat brain and the percent of output of dopamine when studied in comparison to different drugs of abuse. Top left corner, amphetamines, right? Look at that, 1,000% increase beyond baseline. And it's up for hours and hours and hours. Look at cocaine, 400% increase, and it's up for hours and hours. The bottom right here, the opioid class, morphine, 300% up for hours and hours. Now, I want to put this in perspective of how the brain can manage this, right? Let's imagine what happens to another organ system that's exposed to these extreme levels of a chemical from minute by minute, hour by hour, year by year. So let's try it with the heart, right? Many of you might exercise, you go to the gym, and if you go to the gym, you might target your maximum heart rate to be 85%, I'm sorry, to be your 85% of your maximum heart rate. And you'll do that for maybe 30 minutes or so. That helps strengthen the heart. It's got some good data on it. And if you do it for a short period, it's healthy. Tell me what would happen to that poor organ if you targeted 1,000% increase in heart rate for 4 hours. Ask the morgue, right? No organ in our body is capable of managing these extremes. But the brain is absolutely amazing. Instead of exploding unmentionables across our ceiling when we use our first drug of abuse, it adapts, and it adapts very quickly. Within the first couple of days to weeks of use, we start seeing early changes where the brain says, holy moly, all of this dopamine flowing across to the next nerve. I'm doing something amazing for me. I need more, and I need the ability to transmit the signal much more easily. And what we see is that there's increase in all the receptors in that part of the brain to help transmit the signal. I want you to look here in that brain. That the part of the brain we're talking about today is called the nucleus accumbens. And that nerve that's about to pick up the dopamine flowing across from one nerve to the left, I'm sorry, from one side to the other, is called a dendrite. I want you to look under the exposure of amphetamine here on the right-hand side, how big that dendrite looks compared to saline or a control, someone who's not experiencing amphetamines. Now, if you have more receptors, you're going to get a better signal, right? And this starts to change early on the reward prediction, how high that next high will be. Is it worth pursuing, right? The stimulus response, especially after a couple of weeks to months, you might have people that you work with that say, listen, I shot up fentanyl for 6 months in my bedroom. I walk into my bedroom today. I walk into my bedroom today, and without even touching the drug, I get the high, right? That's a stimulus response. That's that Pavlovian response. Approach behavior, what you're willing to do to access that drug, learning, right? How you start changing the way you perceive your environment and your decision making, that frontal lobe, that go, no go center in the brain that should be in control, the one that says this is a good idea or holy moly bad idea, starts to shut down. Your brain cannot keep this production up for long. After a couple of months with those heavier drugs, the amphetamines, many of the heavier opioids like fentanyl, what we actually start seeing is that the brain begins to burn out, and certainly over years. This study has been repeated multiple times, but it's looking at that dopamine receptor availability. How much of those receptors are available to take up all that dopamine flowing from one nerve to the next? Over a matter of months and definitely years, we start to see a rapid decline in the total number of receptors available. Number one, your body says, this is ridiculous. Why am I continuing to produce all of the dopamine? I can't keep up with production. Plus, you've got a whole system in your body that down regulates the amount of receptors to be produced if they're made in excess anyway. Now, I want you to think about this because at the same time, the total amount of dopamine you're producing also goes down. So, if the amount of dopamine is baseline low, if the amount of receptors you make is baseline low, and you hug your kids in the setting of all of these changes, what do you feel? Nothing, right? The only way to feel any sense of pleasure in that body is to be using that drug of abuse. And what we see is this transition over weeks to months with some of these heavier drugs, where the primary reason for use starts to switch from positive reinforcement, where the initial reason for use, right? And we'll go over these in a minute, was either the euphoria or the pain alleviation in the setting of opioids or mental health alleviation. And in a setting of controlled use, where you in that frontal lobe is in control, to more and more impulsive use, again, over weeks to months, to a state of negative reinforcement, where your primary reason for use is to get out of all the symptoms these drugs are causing and to stay out of a state of depression. The problem is your body has been rewired and you are now in a state of compulsive use where that frontal lobe is all but shut down and where that pleasure center is on overdrive, making decisions. This study has been repeated numerous times and it's looking at the rewiring and the connectivity pattern in the brain. I want to focus here on this left blue circle. That is your frontal lobe connectivity. All those little red polka dots are your frontal lobe. All these other colored polka dots in each of these other sections represent other parts of the brain. I want you to look here at the subcortical area in yellow on this left-hand side. That is your limbic system, your pleasure center. Now, first thing you're going to notice is that there are very few robust connections between your pleasure center and your frontal lobe. What's that mean? That means that if you're going to do something pleasurable and you want to react to it, it has got to go through a whole lot of brain processing, all these other connections, right? You got to get on the 35W, then you've got to head down to I-94, and then you got to take the 101, and then Highway 62 for another 20 miles in order to get to that frontal lobe where that decision is processed and your brain says it's good or it's bad based on how you feel. I want you to look here on the right-hand side. This is an individual who's got a history of heroin use. They are abstinent right now. I want you to look at the connectivity patterns. Look at all of these functional connections between different parts of the brain and look at how many of them are wired directly to that pleasure center. Most importantly, in my imagination, look at that connection between the pleasure center and that frontal lobe. Who's in control? Look at this, the 5-lane bike path, right? That's been built. The freeways that are going directly there and not the back way they're supposed to be. I mean, we have sabotaged the connection system in that human brain, and the pleasure center is in control. The frontal cortex or your go no go center has been overridden. Ladies and gentlemen, I want to imprint this on your minds because what you're looking at here is addiction. And what you're looking at here is what addiction looks like even 15 years out in a state of abstinence. That doesn't mean that because this brain continues to be rewired to this degree, that that person is living in a state of dependency. It means that we recognize addiction as a chronic medical disorder. And this is why it's so important that we take care of people from that biopsychosocial spiritual treatment profile, that we make sure that we have relapse action plans, that we not offer them opioids or other drugs of potential abuse inappropriately if they don't need them. Because, ladies and gentlemen, all we're doing is putting cars back on roads built in the brain. Now, the data shows we can rewire this to a degree, and there are ways to do that. But friends, I would make the argument today that the mind is a prison in the studying of addiction. Profound withdrawals for many of these people, whether they be physiologic, right? You have opioid receptors throughout your body, top to bottom. And when they have been bound with opioids for a long period of time and they are no longer bound, you feel everything falling apart. Nausea, vomiting. It's the worst stomach flu you ever go through in your life, right? You can't see, you're sweating, you're curled up in a ball with pain. Think of all the memories that you've built up, right? The relationships you've destroyed, the people you've hurt. There's physiologic pain, especially with opioids, when you're going through withdrawals, and that can last for weeks, if not months, in many people. Anxiety is big. There have been studies, and people experience anxiety to very high levels. Loss of executive function, we talked about that. And then this dysphoria, right? You've got a part of the brain called the habenula, and it's this little area that activates during drug use to make you feel like life has no purpose. Now, when you're not using drugs, right, you realize that life has fallen apart and you may feel like there's no purpose. And then when you use drugs, you feel even worse. This is a prison, friends. And I would make the argument today that no one chooses addiction. Who would? You may have chosen a path to it, but that end state of the rewiring, the neuroadaptation, the hormonal changes, all this stuff together, I believe no one chooses that and no one would want to. And friends, what you're seeing here is why the American Society of Addiction Medicine, and I recognize this is an older definition. I like this better than their newer one because I think it calls the domains out better. They used to say that dysfunction in these circuits, right? These circuits, which include the primary chronic brain disease of brain reward, motivation, memory, and the circuitry, leads to these characteristic biological, psychological, social, and spiritual manifestations. What are we looking at on this slide? Friends, this is an image of substance use disorders, right? This is a heat map. On the left-hand side, you see it white colored. That means not many changes. And all the way to the right-hand side, that would be recognized as more severe substance use disorder. That also correlates with more severe brain adaptations in most people. What I want to impress on you today is the argument that addiction is a separate concept from substance use disorder. Heresy? Absolutely. There's a reason for it. Are all fruit apples? Absolutely not. Are all apples fruit? Absolutely. There is a reason we want to start recognizing the term addiction independently from substance use disorders. It's because there's different grading of substance use disorders, but addiction in itself is that biological problem. And once people start to understand that, especially if they have lived experiences, they start to understand why we see this as not a stigmatizing term, but as something we need to be dealing with openly and start using the right medications and the right treatments for. We know in the world of addiction, there are three main pathways in the world of substance use disorder to creating addiction. One of the most common ones, recreational use. We see a lot of this with the amphetamine categories, the cocaines, the stimulants, right? Vaping, you could put cannabis in there, opioids. And this is where we're using those drugs for recreational entertainment, social engagement, having fun. The problem is that you're going to score a couple of points with substance use disorder for use, right? So you've crashed up your car once or twice. You've only used the drug 3 times. You've gotten into trouble with your family. That'll get you a score for a substance use disorder. That is not addiction, right? Repetitive use over time with these profound changes will over time lead to addiction. Same thing goes for chronic exposure. Opioids are a great example of this pathway where you begin using these drugs potentially for legitimate purposes. Like in the medical world, back in the 1910, I'm sorry, the 2010 era and before, we would use these drugs and we put people on opioids for legitimate medical reasons without monitoring or screening them. And they were never getting a high from use. They were using it day by day appropriately. We'd up the dose because they build up more tolerance and up the dose again after weeks to months to years of use. All of a sudden, providers in around 2010, 2012 would start to pull back saying, you know what, we're seeing complications everywhere else. Sir, we don't want to give you your opioids. And people turned to the illicit market. We started seeing changes in behavior. They never got a high, and you do not need a high or a surge of euphoria to develop neuroadaptive changes in the brain. Chemical coping. We see a lot of this, especially during COVID, where people were using drugs of abuse for mental health alleviation. I can tell you, for many of these drugs, they're the best mental health alleviators on the market. They cure depression, anxiety, past trauma sensations, right? All those things that tend to haunt us until they, as the solution, become the problem. And I can tell you, it doesn't take long. And just like these other issues with current exposure over time, it develops these neuroadaptations that we recognize as addiction. All of these, friends, are substance use disorders, but this, the end stage, these severe to moderate brain adaptations, are the addiction. So, how do we diagnose this? Well, in the world of substance use disorders, we use something called DSM-5. It's a big book, they change it up every couple of years, and it looks at all of these behavioral features. Look at all these, right? Using the drug longer than intended, or you can't cut down. If I were to summarize all these, we call them the 4 C's: problems with cravings, control, compulsion, and consequences. Really, the only objective feature we have are at the bottom here: tolerance or withdrawal. So, what do we do with this information? We treat addiction and we treat the whole person with it. When it comes to treating addiction, oftentimes, depending on the group you ask, you get a different answer on the right approach. And I would make the argument today, if you're asking the question, how should we treat it? Well, it depends on what you're going after. The disease, right? Those neurotransmitter problems, the receptor deficits, all the hormonal changes, the anxiety, hormones, CNS rewiring, the medical complications, the withdrawals. Ladies and gentlemen, if you go after those, I can guarantee you, you are not getting your patient back because the patient is independent of the disease. That patient is still a loved one. They're still a taxpayer, right? A mom or a dad or a brother or sister. They're still a citizen, right? Or someone that could contribute to society, someone that could have a job, a body, a soul. Friends, we can use medications, we can use certain treatments to go after the disease, but it is imperative we still go after the whole person. And that whole person is important because recovery is not abstinence. Abstinence is the absence of the drug use. Recovery is a person who's back with their life in society, functional and living. Healing takes the village. This means that we go after the person from the biological, the psychological, the social, and the spiritual approach. And when we go after each of these domains, that's when we start to achieve recovery. So, in the world of opioid use disorder, if we go after these biological things, we recognize tremendous value to these medications, specifically these 2 drugs, buprenorphine or methadone. Both of these drugs have been identified as reducing mortality by 60%. 60%. Now, we used to call it MAT. Sometimes we still do, but the reality is that it was a bit of a misnomer because the sentence itself suggested maybe we could use this as adjunctive treatment, when in reality, the data shows that it should be the primary first line treatment for moderate to severe opioid use disorder. In fact, if we send a person with opioid use disorder to a treatment program that doesn't offer these, the data shows we increase mortality by 77% compared to no treatment at all. I want you to think about that. You send them to a program that doesn't offer these, they were better off shooting up fentanyl under the bridge the week before than going to a program that doesn't engage them. Because the reality is that they're going to try and engage, and then all those things that start to fall apart that we looked at, right? All of the symptoms, the signs, the depression are going to start taking over life, and they're going to leave that program. But in that week to 2 weeks, they have lost tolerance. And with 5 out of every 10 pills out there of fentanyl now having enough to kill the average American adult with one use, it's a death sentence. They do other things. They help us engage in treatment. The data shows they help prevent secondary illnesses like hepatitis and HIV. They help prevent illegal activity, improve functionality. They help reduce cravings. All of these symptoms help a person, or when reduced, engage in treatment. And when you can engage in all these other forms of treatment, like licensed counseling and social services, you get your life back. Despite this, across America, 90% of, or I should say 90 to 80% of people are still not receiving treatment. And the data shows if you put a person in treatment without it, 90% with opioid use disorder will be back on their opioids within 1 year. In the vast majority of cases, within 3 months. We've got to be offering these. Behavioral health interventions are so key. This is an entire field of science, especially when done by individuals with licensed backgrounds. The data shows that it actually activates that frontal lobe, right? That area that's been hijacked by the limbic system. With both motivational interviewing, cognitive behavioral therapy, and other forms of counseling, you can strengthen those connections where they really belong to be connected. And we can change that pattern of that hyperconnectivity that we saw on that other slide. It is key that we're offering this to patients. But what's the point of all of this if at the end of the day, we don't offer people all the things they need to regain their lives? That's housing and food security, making sure they have a job when they leave a treatment program, the legal support or other step-down treatments, going from higher level to lower levels of care if needed, support group engagement, sponsors, relapse action plans, and naloxone, they gotta have that. A long-term provider if you're gonna leave a program that can offer MOUD in the outpatient setting, all these things, right? If you kick them out of a treatment program, and I will say we've noticed this here in Arizona, that it is prevalent to go from a treatment program to nothingness. There was no point when you look at the national data of offering treatment to begin with in many cases, because if they leave that program and they've got no food and their kids are still in the social service program and they don't have a job, who wouldn't turn back to the drug class? Offer them. When it comes to spiritual and religious practices, the data shows that 86% of all clients are looking for this to be integrated in, or at least assessed at the beginning, because it offers things that all these other topics we've addressed don't. A sense of purpose, right? A community, offer the sense of restoration or inner peace, forgiveness. The data shows that you can dramatically reduce substance use and employee prevention if you engage them with spirituality, if that's something important to them. Please make sure it's being assessed and offered. So, do standards of care in the world of addiction exist? For the longest time, we didn't have great standards. The American Society of Addiction Medicine, the AAP had put some out, but it wasn't really until opioid treatment programs, or OTPs, started to engage those at least in specific environments as best practices. And from there, a natural outworking to a document came out earlier this year in January by SAMHSA. It's called the National Guidance on Essential Substance Use Disorder Care. This document, I believe we're going to upload and make available to all of you today, has since been put behind a firewall. Don't get me started. It is a tremendous, nice summary of all of those things we should be offering if a person enters a specialty substance use disorder treatment program. We consider these now to be standards of care in the industry because they align with our standards of care. So what's the definition of a standard of care? Essentially, the degree of care that a prudent and reasonable individual is expected to exercise when faced with comparable circumstances. I would make the argument today, friends, that these standards, as outlined by SAMHSA, are best practices and emerging standards of care in this substance use disorder industry. All of these are major categories as outlined in that SAMHSA document that we should be assessing for and or treating in the event a person goes to a treatment program. Making sure language is correct, right? Is this person speaks Spanish and they go to an English speaking program, it's not going to help. Comprehensive assessments. This means using validated treatment scoring systems. I can tell you I am familiar with many treatment programs, at least in my state, where you come in and their assessment of depression is a checkbox on a form they have self-derived that says, are you depressed? That is not an assessment. Make sure your treatment program is doing it the right way. Drug and alcohol testing, making sure we're looking for other infections that might have come along with their substance use history. Counseling services, right? And by licensed professionals. This is key. Remember, we'll go back to that image that says that if you're losing licensed professionals, you're going to get good outcomes, remodeling that brain. Clients need to have education on what we're talking about today. What is addiction? As well as all of those other things in their life that they need to get back in order, including their own health. Nicotine replacement, MOUD, MAUD, making sure that we've got other treatment support services for recovery, peer mentors, discharge planning. I'll tell you, all of these things that you're seeing on this slide are essentially standard of care in our medical field. We're starting to see these move over to the behavioral health field as best practices, but we're not there yet. When you're looking for a program, look for these things as being offered. All of these things in this document are supported by the medical realm, the American Society of Addiction Medicine, AAP, and then licensed behavioral health fields. These are critical to begin integrating into our treatment programs. So how do we know a treatment program is doing well with this? Well, quite frankly, it's hard to tell. Sometimes state programs that offer licensure through departments of health or state Medicaid systems will integrate them in. Accreditation and certification is one way to really make sure your program is doing a good job with these. Accreditation can be through the Joint Commission or CARF. Both of them are for behavioral health facilities in particular. You can go above and beyond and get CARF ASAM certification. And when we look at heat map analyses of all these elements of the SAMHSA document compared to the required components in these programs to get certified or accredited, they're matching up really nicely with those best practices of care. So at the end of the day, how do you find a good treatment program? Number one, look for a licensure status. That's a good place to at least start for most programs. Are they state licensed? I'm familiar with many, many, many states where you can operate a program and not be licensed. Accreditation and certification is just another level to go above and beyond. That helps as well. Make sure your clients are screened for the right environment. Many treatment programs are more than happy to take your clients independent of what that ASAM screening criteria is, meaning do they need a residential treatment program or can they get away with an IOP or just partial hospitalization? What do they need? Screen them, put them in the right environment for better outcomes. Ensure your programs that you're sending them to are using validated substance use disorder mental health screening tools and assessment tools. And then ask about what metrics they're monitoring internally for optimal outcomes. I can tell you in the healthcare field, we are monitored from top to bottom, right? You give an aspirin to patient, and there are 100 people overlooking your shoulder to make sure that aspirin went in on the right patient at the right dose for the right reason, and that there's good outcomes associated with that aspirin use. Ask about licensed and credentialed staff use in programs. Oftentimes, we're using individuals primarily in therapeutic interventions that don't have those backgrounds. And although they're great for support staff, we've seen concerns across the nation if they're overused beyond their capacities. Make sure there's warm handoffs at program discharge to the next level of care. Friends, there's a lot of ways we can end addiction, starting with prevention, understanding the biology that keeps our patients trapped, and making sure that we treat the whole person, not just what we see as the disease, and helping people know that recovery is within reach. There have been a study done about 3 years ago, a national survey of all Americans, or a good portion of them, I should say. And it identified that recovery was identified in 75% of people who endorsed a history of a substance use disorder. We can get people back. It just takes time and the right treatment environments. We get one shot to get this right in the opioid epidemic. So please employ best practice principles when taking care of patients. If interested, I have a book on this written in conjunction with our opioid stewardship program called Ending the Crisis. Many of the topics we talked about today are in there. There's a lot of other validated resources out there for patients and families. So please use them, use standardized handouts when possible to educate. And I'm going to pause here because I believe we have a few minutes left for questions as well.
We do. And thank you for that presentation. I think it was so comprehensive and a topic that we need to look at, right, when we talk about the scope of addiction. I know we have a poll for our attendees right now. If you have any feedback, we appreciate it from today. And I know we have a lot of questions popping up in the chat. But Dr. Geiger, can you speak first about any resources or tips for family members or friends who have someone who has substance use disorder, is battling an addiction, what they can do, where they should go, and I guess to help get them access to treatment and recovery, and also for recovery support, which I know you touched on.
Absolutely. You know what? I wish we had a national website that had all the best of the best treatment programs listed on there. When it comes to substance use disorder for the opioid world, you can look up OTPs nationally. That might be one way to approach that in your own state. Now, even being an OTP, oftentimes there's variable degrees of how well these programs operate. And so that pre-screening component on you, the family, or you, the patient, is so key. Calling up programs and asking what services they offer. Are there licensed staff, right? Do you employ medications? Do you employ mental health professionals for screening? These are key questions. And then ask about an assessment. Do I or do my family member get a comprehensive assessment on intake to make sure I'm even being put in the right environment? If the answer to those is yes, you're on a good path. And then, of course, states have very specific website information, oftentimes that lists out treatment programs that are licensed. Again, that's always a good starting place. Making sure to check into that would be key as well.
Thank you. And can you talk about the emerging threats of the opioid crisis, the synthetics, the xylazines and the chronomes, the gas station heroin, things like that, and what you're seeing on that and the impact on the brain?
I'm scared. I'm very scared. So we recognized fentanyl, right? A drug that's upwards of 100 times more potent than just oral morphine, to be our greatest threat over the last probably 10 years or so when it comes to synthetic opioids. But there's an emergence of new trends of NPOs, or novel potent opioids, that are emerging on the market. These NPOs are upwards of 1,000 times more potent than standard opioids. And carfentanil, something that requires 2 grains of salt worth to kill the average American adult, is increasingly available. In Arizona, I'm home to where 55% of all fentanyl and NPOs are trafficked through to the rest of the United States. We are the border state right now. And I can tell you, we're seeing trends in my own state where these NPOs are becoming more prevalent. Brorphine is a more common one. As we think about how these drugs are impacting our communities, those who use these drugs for the first time will overdose and will likely die. It is very challenging to resuscitate these individuals. It's only those who are highly tolerant to fentanyl already who will survive that. Right now, we're seeing 3 to 4% market share on the East Coast of NPOs taking over fentanyl. That's scary. And of course, we're already in the fourth wave of the opioid epidemic, that fourth wave being concurrent usage of other drugs of abuse, primarily the amphetamine class. 80% of all deaths associated with the stimulants right now have a active opioid ingrained in it that that person either wanted or was unaware of when they used that product. So it's a bit of a mess out there. Kratom, the gas station drug, it is not technically federally licensed as anything. And that scares the heck out of me because it binds to opioid receptors. There is a different point of view in the pharmaceutical world than there is the government as to whether or not something is essentially in a drug class. If it binds to that receptor, it is an opioid. we look at it in this medical world as an opioid. So please keep your kids away from kratom, stay away from it. It is a potential drug of abuse, and those that are transitioning from opioids over to kratom are just on another pathway for long-term dependence to something new.
No, thank you for that. And also about the sharing about, the amount of other drugs that we're seeing right in this fourth wave being used with opioids. I think it's so important to be aware of that. I know we're coming to the end of our time. We have about 3 minutes left. I just want to just go to you, Dr. Geyer, with anything that you haven't been able to touch on or you think is one of the most key factors or key points that you would like our audience to take with them today.
Hope is within reach. I had my daughters being babysat by a woman, and at the end of the day, she had spent all day watching my three little kids. She was a third grade teacher, and I walked her out the door and I said, "You have a short ride home?" And she said, "Well, I'm going to be driving around for 3 hours." And I said, "Tell me why? Where do you live? Right? And Phoenix isn't that big." And she said, "Well, thank you for the opportunity to watch your kids. I needed the gas money. I'm going to spend my time driving around Phoenix looking for my daughter. She's on the streets, stuck on heroin, fentanyl." Um, we live in a world where the drugs are too accessible. We live in a society where we have a pill for that mentality. And I will say prevention is so key. But for those who do struggle, we've got validated treatments that are available. Chase them, use them, and don't be afraid for a single or two relapse because it's oftentimes the norm. That is not failure, it's the disease. And we're going to help you through it in the medical world.
I think that's really a great note to end on. So thank you so much again for your presentation today. Thank you so much to our audience for joining us today for this really important conversation, right? So this, when we talk about opioids and we talk about one drug, and I know there's a lot of questions about other drugs in the chat, but looking at addiction as a whole is so important. And I'm so glad that we had the opportunity and that you had the opportunity to be with us today, Dr. Geyer. For all of our attendees, we hope that you can join us uh, next month as we re-examine the opioid crisis and do a year in review. We have Captain Jason Pietrowski from the Jersey State Police who's going to give us an overview of trends that we're seeing from a law enforcement perspective. So looking forward to that, and that will be on Thursday, December 4th. Thank you again, Dr. Geyer, for being with us. Thank you for all of our attendees for joining us today. And you will get a copy of today's presentation and a link to a video of today's presentation as well. And I wish you well. Have a good day, everyone.